can hear that.
My practice, at least in DFR, when the tandem lesion says I actually put left main to circumflex and get the left main, and if I put the left main into LAD, I get that one. So it's always very difficult in tandem. Sorry for the time.
Thank you. Assalamualaikum. Very good morning to you all. This is, I'm going to show two cases. That is double bullet, but single or double barrel gun. That is the question. So, it's not moving. Anyone can please help me? It should be written. Sorry for interruptions. Case 1, 32 years, a smoker shifted from another hospital to my hospital with acute diagnosis of acute inferior myocardial infarction 2 days back. And patient presented in our hospital at 10 p.m. With anterior myocardial infarctions. So, patient admitted in that hospital with 18-hour chest pain, where patient was diagnosed with acute inferior myocardial infarction. As a presentation, patient was being given low molecular weight heparin. And at our hospital, patient was hemodynamically stable, and we planned for primary PCI and taken to catheter. And this is the ECG in the previous hospital, where patient was diagnosed as case of inferior myocardial infarction with 18-hour chest pain. So in our hospital, the next day, it is around 10:55 a.m. and this is clear-cut anterior myocardial infarctions. So what is the lesion? Anterior myocardial infarction due to RC occlusion, then anterior MI due to the LAD occlusion. Or type 4 LAD lesion with distal embolization of the thrombus, producing inferior myocardial infarction, then re-occlusion producing anterior myocardial infarction. Or simultaneous development of inferior and anterior myocardial infarction due to type 4 LAD occlusion and ST resolution in anterior due to the recanalization and again development of re-infarction. That would be the possibilities. This is the angiogram. So there is definitely LAD 100% occluded proximally. So in his study, 159 patients with occluded LAD and found that 25 patients had simultaneous ST elevation in anterior and inferior ribs. They have defined wrapped LAD that perfuses at least 1/4 of the inferior wall of the left ventricle in the right anterior oblique projection. There were 4 conditions in cases of LAD occlusion according to the existence of the wrapped LAD. Number 1, if the patient has a wrapped LAD and the location of the occlusion is proximal to D1, ST segment are elevated in the anterior ribs and remain isolated in the inferior ribs. If the patient doesn't have any wrapped LAD and the location of the occlusion is distal to the T1, ST is elevated in the anterior ribs and remains within isolated in the inferior ribs. But if the patient doesn't have a wrapped LAD and the location of the occlusion is the proximal to D1, ST is elevated in the anterior ribs and ST depressions occur in the inferior ribs. But if the patient has a wrapped LAD and the location of the occlusion is distal to D1, the ST segment is elevated in the anterior ribs as well as in the inferior ribs. So this is the case. Really, it is LAD occlusion after D1. So we plan to do primarily the thrombosuction was done and put a stent there. So it is go through revascularization and definitely it is type 4 LAD. Patient was discharged. So this is the ECG. So it is definitely a double bullet, but from a single barrel gun. So take home message of this patient is for double wall MI in same sitting, always in single vessel occlusion or anomalous origin of RC from LAD and occlusion of vessel, this proximal to RCA. But in second case, patient 62 years, diabetes, hypertension, transferred to our hospital emergency department. After 2 days of diagnosis of anterior acute myocardial infarction inferior, and got STK in that hospital, and patient was transferred through ambulance, where patient experienced chest pain and for a short period of unconsciousness. Then at our emergency, patient was seen our specialist, and I was called to see the patient, but I was busy in the cath lab. So patient was transferred directly to the cath lab, and this is the ECG. Then this is very tall tented T-wave, so definitely we might have some differentials. At the same time, it is 2:1 block. So definitely hyperkalemia could be an option. So I did not take the patient directly to the cath lab cabin. Patient was beside the cath lab cabin, and I immediately draw the blood for ABG, and we could find potassium level, it is 4.5. Then I decided to take the patient to the cath lab. In the meantime, patient was in blood pressure is low, so I started doing angiogram. So this is the scenario. So heart not contracting well, already shown it is 30% ejection fraction. L6 is also disease, and it is dominant vessels, and LAD, there is a thrombus in the ostia. So this is a very bad scenario, and RCA is definitely very small vessel and diffuse with disease. So patient is in great conditions. So we start the thrombus, double wide. We have taken both, we wired both the LAD and the LCX, and we start the thrombus first. Then we put stent first in the LCX, then left into LAD. And this is the final shot. So both the vessels are revascularized. Then we send the patient to CCU, where patient developed bradycardia, and atropine was given. Patient developed flush pulmonary edema with high blood pressure and sinus tachycardia. Then patient was intubated and resuscitated. In the next day, patient was extubated by good luck. And on the 5th day, patient was discharged with 50% ejection fraction. Initially, it was 30%. So this is the ECG after ECA, after 1 day, not that day, after 1 day. And so it is double bullet, double barrel. Polakitov found 18 cases, 2.5% of the multiple culprit arteries in the series of 711 patients underwent primary PCI. This discrepancy is probably due to the selection bias in that patients with multiple culprit arteries are more likely to suffer sudden cardiac death, not surviving long enough to undergo angiography. The results of Polakitov highlight the severity of the clinical symptoms associated with this condition, since 1/3 of the patients presented in cardiogenic shock and a quarter had potentially fatal arrhythmia or required intra-aortic balloon pump. Although the factors involved in simultaneous acute thrombus of the multiple coronary arteries are not fully known. Possible causes include heightened inflammatory response at catecholaminergic starts caused by the acute occlusion of the one vessel leading to a second coronary artery occlusion. Number 2, hemodynamic instability and hypertension due to the occlusion of the one coronary artery resulting in blood stasis and acute occlusion of the another artery with the severe underlying lesions. Prolonged coronary vasospasm could be the one possibilities, and a hypercoagulable state including malignancy, hyperhomocystinemia, and thrombocytosis, and coronary embolism at the cause. So my take-home message: sequential myocardial infarction may be due to single vessel, most commonly LAD wrapped around, or may be due to the double vessel involvement as well. In spite of successful thrombolysis or PCI, almost 1/3 of the patients die of multivessel myocardial infarction. Very early intervention might improve the survivability. Thank you. Thank you all.
Thank you, Dr. Shafiq, for the two interesting cases. Any comments or questions from Professor Azad? So, any comments or questions?
First one is not a double bed because this is because of the one vessel that is irritated. No, that was double bullet, but single barrel. Because from one barrel, that is the LED, made two infarction, inferior and anterior. That is why I told it is single barrel, but double bullet.
Definitely. What you can also explain, if there is a MI in the inferior one, that is already recanalized. Then there is second event in the
What I told, that was in, that already been told that that is embolization of the thrombus from the proximal LED that produces the inferior MI, and that reocclusion of the proximal LED again producing anterior MI. That could be the possibilities. Thank you, sir.
Okay, I think so. All of the cases are great. Shafiq, what is the actual take-home message from your cases that we would like to give to the audience? Because you have done target research reverse correlation. And my second question is that why the patient was developed subsequently on the that is cardiogenic arrest, or you have put the patient on ventilator? That's right. Why this happened?
Actually, patient might have vasovagal. That is why heart rate was decreased. And later on, patients got the atropine. Later on, heart rate increased, and at the same time, blood pressure increased. But patient ejection pressure was too low. There was flash pulmonary edema. Then patient was intubated.
Okay. But ejection pressure is not too much low, 50, 55?
30%.
30%.
At the time, it was 30%.
And what is the actual take-home message?
Take-home message.
All the cases.
Double AMI is always very difficult to treat, and it should be treated continuously. And all the that is, patients should be resuscitated properly. Otherwise, 30% patients die even after PC. That is very important. So we need to have intra-auricular development at the site if at all needed. That is very important.
Dr. Shafiq,
Yes.
what is your explanation about ejection fraction? Before it is 30,
Right.
after PCI it is 50. How to explain?
In case of any myocardial infarction, definitely there is a stunned myocardium, and after defarcation that gets a better movement. That is why it increased later on. So on discharge it was 50%.
Thank you very much.
Thank you, Dr. Shafiq.
Thank you.
Now we have to move to the next case. Our presenter is Dr. Mohammad Muhammad Arif.